Hi, my name's David Berg. I am a cardiologist and an intensivist at the Brigham and Women's Hospital at Harvard Medical School, and I am an investigator in the TIMI study group. Of trying to answer what's the optimal thromboprophylaxis strategy in critically ill patients with COVID-19. The COVID-PACT trial was a 2x2 factorial randomized controlled trial in critically ill patients with COVID-19. So unlike some other studies, including the multi-platform trial, which looked across the spectrum of acuity, COVID-PACT really focused on the critically ill patients. Patients underwent randomization to either full dose anticoagulation or standard dose prophylactic anticoagulation as a strategy. So individual clinicians could decide about using either a low molecular weight heparin or unfractionated heparin initially. And then if patients were not already on an antiplatelet agent, such as aspirin or clopidogrel, there was a second factorial randomization to either antiplatelet therapy with clopidogrel or to no antiplatelet therapy. And patients were maintained on those therapies while they were hospitalized or through day 28 post-randomization, which was the study end date. The primary endpoint in the study was a composite of thrombotic events, and that included both venous and arterial thrombotic events. Venous thrombotic events being pulmonary embolism, deep venous thrombosis, arterial thrombotic events being type 1 myocardial infarction, ischemic strokes, systemic embolic events, or acute limb ischemia. So that was the sort of the fundamental design of the trial. What we found was that patients who were on full dose anticoagulation had a significant 44% reduction in the risk of the primary endpoint. So a 44% reduction in the risk of thrombotic events when they were treated with full dose anticoagulation. For the other comparison of clopidogrel versus no antiplatelet therapy, there was no benefit of clopidogrel on the primary endpoint. And so those were I think the principal findings of the study. From an efficacy standpoint, as I mentioned, what the COVID-PACT trial showed is that full dose anticoagulation reduces thrombotic complications in critically ill patients. But of course, the flip side in any study of an antithrombotic intervention is what's the effect on bleeding? And there's different levels of severity of bleeding. And so there were two safety endpoints in the trial. The primary safety endpoint set a higher bar, so it was fatal or life-threatening bleeding. There were numerically a few more fatal or there were no fatal bleeds, but there were numerically a few more life-threatening bleeds on patients on full-dose anticoagulation. But those events were extremely rare, and that difference did not achieve statistical significance. What we did see is that there was an increase in the secondary safety endpoint in patients on full-dose anticoagulation. The secondary safety endpoint was a composite of what's called gusto, moderate, or severe bleeding, which there's a number of different bleeding definitions out there, and this is a sort of a pragmatic bleeding definition. But that increase in bleeding for patients on full-dose anticoagulation was dominantly driven by an increase in gusto moderate bleeding. And gusto moderate bleeding refers to patients or bleeding that results in any blood transfusion, but does not result in hemodynamic compromise. And so what we saw is that essentially sort of bringing it all together, that a strategy of full dose anticoagulation in critically ill patients with COVID-19 reduces thrombotic complications and increases bleeding, dominantly bleeding that results in blood transfusions, but does not result in hemodynamic compromise. I think that is precisely the question, and so I think to reiterate the findings in the study were that a strategy of full dose anticoagulation reduces thrombotic complications at the expense of some increase in bleeding risk, but not really fatal or life-threatening bleeding. But the question then, of course, is how do we integrate this information, and how can we use this to inform clinical practice? What I think in the aftermath of the multi-platform trial, how clinical practice evolved was to start using full dose anticoagulation in patients who are hospitalized but not critically ill, and then not to do so in the critically ill cohort. even though that's the cohort where the thrombotic risk is the highest. And I think, as we think about integrating the results of the multi-platform study and the COVID-PACT trial, what our trial, should do is give some confidence that we are affecting an important endpoint by using full dose anticoagulation in critically ill patients. So we're reducing thrombotic complications, which is a big problem in patients with COVID-19. And I think putting this all together really suggests that there is benefit of full dose anticoagulation across the spectrum of acuity in hospitalized patients. Perhaps in the floor patients, it's to decrease the risk of COVID-19 progression, but by the time they get to the ICU, we may not be changing the risk of COVID-19 disease progression, but because that group is at such high risk of developing blood clots, we're effectively decreasing thrombotic complications in that population. And so I think the take home really is that in appropriately selected patients, not necessarily patients who are at very high risk of bleeding, but in patients who are not necessarily at high risk of bleeding, a strategy of full dose anticoagulation makes sense in critically ill patients with COVID-19 as well.